Welcome, everybody. Thank you for joining us today. This webinar is a part of our Survivorship Champion series. My name is Dr. Veronica Peniotu, and it is an honor to have you today. I'm going to introduce our guests, but first, some housekeeping notes. Know that the slides presented today and the recording of the presentation will be available to you via email in a few days. And so know that we will have the slides for you and a recording of this webinar. And so it is my honor to introduce to you our guests who will talk about family building and cancer, Dr. Elizabeth Constance and Megan Scherer from Worth the Wait, Executive Director. So I'm going to pass it off to Dr. Constance, and thank you so much for joining us today.
Well, thank you so much for having me. Are you seeing the slides okay?
Yeah.
Okay, perfect. Well, as she mentioned, I'm Dr. Elizabeth Constance. I'm so glad to be here. I am a reproductive endocrinology and fertility specialist and director of the fertility preservation program at the Heartland Center for Reproductive Medicine in Omaha, Nebraska. And I'm really happy to be talking about a topic that is very near and dear to my heart, which is fertility preservation and family building options, both before and after cancer treatment. So I have no financial disclosures. However, during this talk, I will be discussing the off-label use of medications often involved in standard fertility treatments. And so these are the objectives for today. So starting with the basics of female reproduction. The female reproductive tract consists of the vagina, uterus and cervix, fallopian tubes, and ovaries. The ovaries really serve two key important functions. First is that they make hormones like estrogen that are important for bone and cardiovascular health. And they also house the resting pool of eggs, which are necessary for conception. Every month, when someone is having regular menstrual cycles, we have a group of eggs that all get activated together at the same time. One of those eggs gets selected at random to become a dominant follicle, which grows and matures until it gets released in a process called ovulation. When pregnancy is happening, sperm transport happens through the uterus, through the cervix and uterus to the fallopian tubes, which is where the egg and sperm meet. Fertilization takes place in the fallopian tubes, and then the embryos go back the other direction into the uterus, where implantation and fetal growth occurs. So both the egg number and egg quality play important roles in fertility, and abnormalities in either one of these can result in reduced fertility potential. The term ovarian reserve then is used to describe that relative number of eggs in an individual's ovaries. And this is based on the fact that women are born with all of the eggs that they have for their lifetime. And that number then goes down over time. That process of decline actually starts even before birth. Either a lower than expected starting number or an accelerated rate of decline can result in low ovarian reserve. And this can lead to both difficulty getting pregnant as well as earlier than expected menopause, which is that stage when menstrual periods permanently stop and represents the end of a woman's ability to conceive using her own eggs. So if we focus now and zoom in on that portion of the graph that represents a woman's reproductive window or the time in life where pregnancy is most likely to occur, we can see that natural fertility begins to decline around age 35 with a significant decrease in reproductive function after age 40 due to a combination of that decrease in both egg number and quality. As we mentioned previously, all of the eggs available develop before birth and are then paused in their development until the time they're selected to be released or ovulated and potentially fertilized by sperm. The longer that eggs are in that resting or paused phase, the less efficient the machinery inside the egg that's responsible for replication of genetic information is when it begins working again at ovulation. So this is the process we're describing when we talk about egg quality as opposed to egg number. So this decrease in egg quality or the efficiency of reproduction of genetic material leads to both decreased pregnancy, which is the solid blue line, as well as increased miscarriage rates or that dotted red line over time. Unfortunately, treatments like chemotherapy and radiation can accelerate this process of egg loss, sometimes leading to infertility and early menopause. So chemotherapy and radiation are very successful at treating cancer because, as we know, they target and attack rapidly dividing and metabolically active cancer cells. The downside is that they can't always tell the difference between rapidly dividing metabolically active cancer cells and other rapidly dividing cells in our bodies that are just doing their jobs, like hair follicles, the cells along the GI tract, as well as those hormone producing cells in the ovaries. So, the best of our current knowledge, unlike hair follicles and cells in the GI tract, once these hormone producing cells in the ovaries that support egg growth and development are lost, they cannot be regenerated. So, the extent of this damage is dependent on one's age at the time of treatment, the pre treatment ovarian reserve, and the chemotherapy agents used and their cumulative doses. Radiation therapy can also have a similar toxic effect on the ovaries through direct cell damage and cell death that is also dependent on dose, duration, and baseline ovarian reserve. And then finally, pelvic and abdominal surgeries can have a direct effect on fertility, as scar tissue can alter the anatomic location of the ovaries and fallopian tubes, which can affect normal egg transport and reduce fertility potential. So this table shows some common chemotherapy and radiation protocols and separates them into high, intermediate, and low risk categories in terms of risk to fertility after treatment. There are separate tables available for men and women. This happens to be the table for women. So it's important to note that these percentages listed that we're often quoting when counseling patients are the rates of ovarian failure or early menopause, not infertility. We know, however, that many women who do not go through early menopause following treatment will still experience infertility or subfertility requiring medical treatment. So the impact of these treatments is even higher than what is listed. This is kind of a graphic representation of that table we saw on the last slide. So you can see in the dark blue line is the normal age-related decline in fertility, with that dotted green line underneath showing the associated low risk therapy. Those yellow lines show that toxicity, that wide variety of toxicity in that moderate or intermediate group, and then a very severe decline in the high risk group, which is that dotted red line. So because of this, multiple organizations, including the American Society for Clinical Oncology, the American Society for Reproductive Medicine, and the American Academy of Pediatrics have all published guidelines recommending that all reproductive age patients with a new cancer diagnosis be counseled regarding reproductive risks of treatment and referred to a fertility preservation specialist prior to the initiation of treatment whenever possible. For women who have already been through cancer treatment, an evaluation to assess post-treatment ovarian reserve can be super helpful, even if they're not yet ready or really don't ever intend to have children. First of all, I'm a strong believer that the more information you have about your body, the more empowered you can be in taking control of your reproductive health and future. And even if having children is not something you have an interest in ever doing, which is the case for many individuals, the premature decline in hormone levels associated with early menopause can have profound negative effects on bone and heart health. So identifying a potential issue early can allow us to intervene and protect long-term health completely separate from reproduction. For those who may want to have children now or in the future, identifying decreased ovarian reserve or risk of early menopause can allow us to take steps to preserve future fertility if desired. Ovarian reserve then can be assessed using an ultrasound to look at the ovaries directly. Eggs themselves are too small to be seen with our eyes, but we can see these fluid-filled sacs that we call follicles, which are where the eggs are housed. On ultrasound, we can count these small follicles, which represent the number of activated eggs at any given time. We can also assess ovarian reserve through hormone testing, specifically looking at a hormone called AMH, or anti-Müllerian hormone, which is produced by the support cells in the ovaries that surround the resting pool of eggs, as well as FSH, or follicle stimulating hormone, which is a hormone the brain uses to communicate with the ovaries to grow and mature an egg to be released each month. So this table then shows the normal ranges for the hormones AMH and FSH. And as the ovaries begin to slow down over time due to low egg number, we see the AMH levels decrease. At the same time, the brain starts having to kind of work overtime to get the ovaries to respond and do their job every month. And so those FSH levels start going up as ovarian reserve goes down. By monitoring these levels over time, we can catch these changes early and potentially intervene if fertility preservation for later childbearing is desired. In this, looking at pre-treatment AMH levels in relation to ovarian function. So we oftentimes see immediately after treatment, those AMH levels go down, and then we see recovery. And that recovery period takes anywhere from 6 to 12 months after treatment. Correlates also with what we see in that it can take up to 12 months after treatment for periods to resume. And so for people with a higher pretreatment AMH level, we see a faster recovery at about 12% per month, whereas people who have a lower ovarian reserve with an AMH less than 2 prior to treatment have a slower rate of recovery at about 2.5% per month. So we typically recommend, because of this, waiting until at least a year after chemotherapy and radiation are completed to start monitoring ovarian reserve. And this is because many people will see that recovery we talked about in hormone levels during the first year. And so it can be normal to have that time for recovery. Depending on what those initial levels are, we will then typically follow a person every year. However, more frequent monitoring may be indicated if there's a significant drop or if levels are low enough to consider further intervention. So kind of transitioning now to that male reproductive piece, similar to the ovaries in women, the testicles in men have two primary functions. One is the production of the hormone testosterone, and the second is the production of sperm for reproduction. Unlike women who are born with a fixed number of eggs, sperm production in men begins at puberty and continues throughout the remainder of their lifetime typically. This is possible due to the presence of stem cells in the testicles that drive that continuous sperm production. Sperm is then transported through the epididymis and vas deferens to the ejaculatory duct. And through this transport process, the sperm joins with fluids from the prostate and seminal vesicles, which contain proteins and nutrients that support sperm survival and transport through the female reproductive tract. This process then from stem cell to mature sperm in the ejaculate takes about 3 months. Therefore, any negative effects on sperm number or function due to medications or other environmental exposures can be seen for 3 to 6 months after that inciting event occurs. The effects of cancer therapy on male reproductive potential are also similar to those seen in women. So in men, destruction of a critical percentage of sperm-producing stem cells in the testes by chemotherapy agents may lead to either reduced or no sperm production, which is called azoospermia. Once these stem cells are damaged or lost, that process is not reversible. So the risks and extent of damage to these cells depends on the chemotherapy drugs used, the dose, and the length of treatment. Likewise, radiation therapy has a direct toxic effect on the sperm-producing cells of the testes in a dose-dependent fashion. And finally, pelvic surgeries can impair fertility by impeding normal sperm transit, by causing a blockage anywhere along that transport system, or through nerve damage. And so for those wanting to preserve fertility before treatment, there are multiple options for both men and women, including well-established therapies, as well as some that are still considered experimental, which I have listed here in yellow, and we will discuss all of those briefly. So ovarian stimulation can begin at any time in a person's menstrual cycle using what we call random start protocols. This allows us to start stimulation the same day they present for consultation if desired. It also allows us to minimize any delays in starting cancer treatment in order to pursue fertility preservation. And multiple studies have been done showing no difference in egg number or quality with random start protocols compared to more traditional IVF protocols that begin with the onset of a period. Chemotherapy can begin as soon as the day after egg retrieval, which again allows us to prepare for limited delays in initiating treatment. Egg freezing, as opposed to fertilizing eggs to create embryos, has become the preferred option for most patients, regardless of relationship status, due to both success rates with freezing and thawing mature eggs now being nearly equivalent to the outcomes with IVF using fresh eggs. And additionally, we see that over the last 2 years, we've seen a lot of states passing legislation that impacts the ability for dispositions to be made about embryos. And so freezing eggs versus embryos is both safer from a legal standpoint, as well as leaving options. Or next. or Nexplanon in place. So those do not need to be removed unless there's other indications. So for people with ovaries, the most common method is ovarian stimulation with egg freezing. Importantly, this can only be done for adults and post-pubertal adolescents. So for prior to puberty, this is not an option. Um, Additionally, this process requires multiple ultrasounds, typically vaginal ultrasounds and blood draws. So the person has to be kind of able to go through that process. So it isn't always appropriate for younger adolescents, although that can be really dependent on the individual themselves. On average, the process of ovarian stimulation and egg retrieval takes about 12 to 14 days. And so the individual pursuing this option needs to be able to delay the start of cancer therapy for about 2 weeks for this to be feasible. Additionally, they have to be healthy enough to undergo ovarian stimulation and egg retrieval, including anesthesia required. So we have many studies showing safety and efficacy of fertility preservation. Most of these have been done in the setting of the breast cancer population. And so this is because these women are often younger at the time of diagnosis, as well as the fact that many of these women have hormone-sensitive tumors. Therefore, there has been a lot of research interest in determining whether ovarian stimulation for fertility preservation is safe. However, these findings are applicable to women with other cancer diagnoses as well. And so we have here multiple studies that have been published looking at both survival and cancer recurrence rates in women who pursue fertility preservation with ovarian stimulation and egg retrieval. And to date, all of these studies, including those in women with hormone receptor positive breast cancers receiving simultaneous aromatase inhibitor therapy, have demonstrated no difference in survival or recurrence rates in women who undergo fertility preservation compared to their peers who did not. Another option for fertility preservation before the initiation of chemotherapy is hormonal suppression with a GnRH agonist, such as depo-lupron, although this is still considered experimental. The theory behind this method is that by suppressing ovarian function, those hormone-producing cells in the ovaries are less active and therefore less sensitive to chemotherapy. This preservation of ovarian function is important not only for fertility, but also for resumption of endogenous hormone production, which is important for that long-term bone and cardiovascular health. GnRH agonist therapy can be used alone in patients who can't or don't want to pursue other fertility preservation options, or in conjunction with other methods such as egg freezing. So because of the mechanism action of how GnRH agonists work, the timing of it is really critical. And so the GnRH agonist first dose should be initiated ideally 7 to 10 days before the first dose of chemotherapy. And exceptions for this are for patients who are either already on contraception and therefore not ovulating, or if we know for sure that a person is in that window in their menstrual cycle between ovulation but before the period starts. If that timing is not possible just because of the need to quickly get chemotherapy started, the GnRH agonist can be given at the time of discharge after the first dose of chemotherapy and ideally 7 to 10 days before the second. So typically we start by administering a 1-month dose first to make sure it's well tolerated, and we can then switch to 3-month dosing for the duration of therapy. As with any other fertility preservation approach, it's integral to make sure that there aren't any other contraindications, obviously, before doing this. It's also important to counsel patients that GnRH agonists are not FDA approved as a form of contraception. And so an additional method of contraception is needed if pregnancy is a risk. Ovarian tissue cryopreservation is currently the only fertility preservation option available to prepubertal girls. At this time, there are a limited number of centers across the country who offer this. This option requires surgery to remove all or part of one ovary, leaving the other ovary intact with the hopes of preserving future endocrine function. Strips of ovarian tissue are then frozen for future use. This can be done at the time of another planned surgery, such as port placement or tumor resection for solid tumors prior to starting chemotherapy. And then once the person is ready to pursue pregnancy using this tissue, the tissue can be reimplanted either on the surface of the remaining ovary, allowing for natural conception to take place, or it can actually be transplanted back under the skin, typically in the arm or abdomen, which then would require stimulation and egg retrieval, kind of similar to IVF. Sperm cryopreservation is the fertility preservation treatment of choice for adults and postpubertal adolescent males. Mature sperm is typically obtained through masturbation, but can be obtained through testicular extraction if needed. Multiple collection attempts is preferred in order to bank as much sperm as possible before initiating gonadotoxic therapy. However, there's really no standard currently for how much sperm is considered adequate to achieve a future pregnancy. So that's why we just get a little bit greedy and try to get as much as we can in the time that we have. Collection can often be arranged in the inpatient setting if there is not time or ability to come in for an outpatient collection. For prepubertal boys, testicular tissue cryopreservation is currently the only option for fertility preservation. This is still considered experimental, and again, similar to ovarian tissue cryopreservation, only offered at a limited number of centers across the United States. It is important to note that there have not yet been any pregnancies reported in humans. However, we have had, I believe, 2 now pregnancies using cryopreserved testicular tissue in monkeys. So we're getting close. So therefore, the goal of treatment at this time would be to preserve tissue before cancer therapy in the hopes that the technology to recover mature sperm will be available by the time the patient desires fertility in the future. So then for individuals or couples desiring to conceive following cancer treatment, there are several options, which we'll go into in detail. First and foremost, though, I want to stress that having gone through cancer treatment in the past does not mean that a person cannot potentially get pregnant on their own without medical intervention. Although a history of cancer treatment is a risk factor for infertility, many individuals conceive without medical treatment. However, knowing that this is a possible risk, it is helpful to seek early evaluation to assess personal fertility potential so that intervention for fertility preservation or treatment to conceive can be pursued if needed. Another really important question that is frequently asked is how chemotherapy or radiation may impact a pregnancy in the future. So we typically recommend waiting at least a year after completion of treatment before trying to get pregnant. Of course, with consent, an agreement from the oncology team, in order to reduce the risk of remission as well as any potential risk to the developing fetus. The good news is that when pregnancy occurs at least 12 months after treatment, those babies are not at any increased risk. Women with receptor positive breast cancer may also face the additional need to undergo several years of hormone therapy after initial treatment, which can further delay childbearing. And so this positive study was just published in May of 2023, and it did show that interruption of endocrine therapy up to 2 years for the purpose of pursuing pregnancy did not increase short-term risks, which is super reassuring. However, we do still need that long-term data, which is ongoing. So for people undergoing fertility treatments, oral or injectable medications can be used to stimulate egg production for some women. For women who are not having regular menstrual cycles, but are not in early menopause, medications can be used to induce egg production and ovulation. For women who are having regular periods but are still having trouble getting pregnant, these medications can also be used with the goal of ovulating more than 1 egg at a time. And the rationale for this is that by increasing the number of eggs released, we increase that chance each month of at least one of those being fertilized and resulting in a pregnancy. This treatment does, however, also increase the risk of getting pregnant with more than 1 baby at a time, and so should be monitored closely by your doctor. Intrauterine insemination is the process by which sperm is placed in the uterus around the time of ovulation, allowing for fertilization to take place in the body. This procedure requires a sample containing at least 10 million moving sperm. So this could be an option for men who have reduced but not absent sperm production after treatment, or can be done with sperm that was frozen before cancer treatment. It can also be done with donor sperm for women who are single, women in a same-sex relationship, or women whose partners do not make sperm. In vitro fertilization, or IVF, is the process by which ovaries are stimulated using injectable medications to grow and mature a large group of eggs at one time. So this is the exact same process we use for egg freezing as we discussed earlier. Those eggs are then removed from the body and can either be frozen or as unfertilized eggs or fertilized with sperm to create embryos. This is often the best option for men who have very low sperm counts or a limited amount of sperm frozen before cancer treatment, or women who have had surgery to remove the fallopian tubes, individuals who failed less invasive treatments, as well as anyone desiring genetic testing on embryos before pregnancy. And so just to kind of look at these pictures, and I know they just look like gray blobs to most of us, this top picture is a normal resting ovary, and then this bottom picture is an ovary after ovarian stimulation at the time of egg retrieval. And so each of these big black circles are those follicles that house the eggs. So once the ovaries have been stimulated, eggs are collected from the body through a procedure called an egg retrieval. This is typically done with IV sedation. In that procedure, a needle is passed through the wall of the vagina under ultrasound guidance and then goes into each one of those follicles one at a time, removing all the fluid, and then with the fluid comes an egg floating around in the center. As that fluid is being collected, it is immediately handed off to the embryologist in the lab, who uses a microscope to find the eggs and separate them from the rest of the cells and fluid. By the time the procedure is done, we know the total number of eggs that were obtained. And then again, those eggs can either be combined with sperm to be fertilized or frozen at that time. Once pregnancy is desired, fresh or frozen eggs are fertilized with sperm from either a partner or donor to create embryos. One embryo at a time typically is then transferred into the uterus using a small catheter where the embryo will hopefully implant, resulting in a healthy pregnancy. And so this is, again, is an ultrasound picture of an embryo transfer. So we have the uterus here, this bright white line is the catheter, and then we have a little air bubble up here surrounding the embryo that has been placed in the lining of the uterus. Success rates with this process depends on a variety of factors, and your reproductive specialist should discuss those with you before starting fertility treatment. Additionally, when embryos are developed in the IVF lab, we have the ability to perform additional genetic testing if desired. So this process is called pre-implantation genetic testing, and it involves taking a biopsy of the embryo, which is what's shown in the image here, in which we remove about 5 to 10 cells from the part of the embryo that will form the placenta. Those cells can then be tested for any known genetic mutations carried by one or both parents, such as BRCA, genetic mutations associated with Lynch syndrome, or other hereditary cancer syndromes. This testing is entirely optional, but is available if desired. It's also important to note that there are a lot of ways to build a family. So we've talked a lot about paths to biologic parenthood, but when a patient's own eggs or sperm are not able to be used, eggs, sperm, or even embryos from a donor may be an option. Likewise, for women who are unable to carry a pregnancy themselves due to surgery to remove the uterus or other health concerns, a gestational carrier may allow them to have a biological child as well if desired. And finally, some individuals or couples may choose to pursue traditional adoption or fostering to grow their families as well. So thank you so much again for having me. I will hand off to Megan.
Hi, everyone. My name is Megan Scherer, and I'm the Executive Director of Worth the Wait charity. And I wanted to just thank Dr. Constance. That was such a great and thorough discussion about all the options. And, I know for patients who might be listening, that's a lot to handle. But, I just want my message to be one of hope, of knowing that whether you were able to preserve your fertility before cancer treatment, or you want to start a family today and you're like, oh my gosh, what are my options? I just want you to know that there are so many options out there that you do not need to lose hope. And I've got some really great stories to share that will hopefully inspire you to believe that. All right. So like I mentioned, I'm the executive director of Worth the Wait, and I'm also the co-founder. So Worth the Wait's mission is really personal to me and my husband, Mike. So Mike and I are high school sweethearts, and when we were 26, he was diagnosed with testicular cancer. And sorry about that. And it was really difficult. He was facing cancer and chemotherapy. I was a caregiver. And, we didn't know what our future held when it came to survivorship or starting a family. And once we got through that time period, we realized that we really did desire to be parents. And we were so glad that he was counseled to bank his sperm. But despite that, we went through many years of infertility treatments, and we were losing hope. And in that process, we were spending tons and tons of money on these fertility procedures. We had insurance that covered nothing, and it was a really difficult time. But once we were able to have our son, who we said was worth the wait, we decided that we needed to do something to give back and help other young adult cancer survivors and patients just realize that we're with you every step of the way, and we're also providing that financial assistance, because that gap in access is so large when you think about the debt patients might be in because of being a cancer survivor, and the cost of so many of these ways to build a family. So Worth the Wait's mission is empowering young adult cancer survivors on their path to parenthood. Like I mentioned, we offer financial assistance, but we also do educational and advocacy work as well. And all the photos that I'm using in the presentation today are of real patients that we have helped. So I just want to point out on this page, this sweet little baby. This is one of our Worth the Wait babies. We have 9 of them, and her mother is a Hodgkin's lymphoma survivor. And then the 2 other individuals here are cancer patients who did fertility preservation. So Dr. Constance, mentioned third-party reproduction and all the other options available for family building. So I want to share just a little bit of this story. This magazine cover, the magazine came out in October, and it features my friend, Annie Swanson, and she has the most incredible story. She has metastatic breast cancer, and she was able to adopt her older daughter, who's in the middle in the little family swing. And then her younger daughter was born through egg donation and gestational surrogacy. So I think her story is so inspiring when it comes to, the sky's the limit. When you want to build your family on survivorship, you have all of these options. She took advantage of so many of them, and look at this beautiful family that she has today. So talking about adoption, most people think about like, oh, I'm going to adopt a little baby, a little infant. And while that can be possible, it is a little bit harder to do an infant adoption because of the waiting period. A lot of people think that there is just this huge amount of babies that are waiting to be adopted, but unfortunately, that's not the case. The place where there's a lot of children waiting is in foster care. So I really want to highlight foster to adopt as an option. It's a really great option because it's a quicker process if you're looking to start a family sooner, and it also is a lot less expensive compared to domestic or international adoptions. So I do want to break down the other ones just so you're aware of all of the options in adoption. So domestic adoption, you typically are working either privately with an attorney, or you're working with an adoption agency. And with an agency, they're handling everything. So matching with the birth mother, typically some counseling beforehand, and it's really just a seamless process. And then as far as international adoption goes, there are certain countries where you can adopt children from, and some of those countries are open to cancer survivors. and some are not. So it's really important, if you're interested in an international adoption, you work with an agency who's well versed and knows all the ins and outs of the countries. For instance, I know just through our work with Worth the Wait, Colombia is a country that is open to working with birth parents who are cancer survivors, whereas some countries, they're just not willing to have that go through. And then probably if you know someone in your life who is not a child who's adopted, chances are they had a closed adoption. That really used to be the norm. So a closed adoption means, you have no contact with the birth parents, the birth family. However, as things like DNA testing is more readily available, and the ability to search for relatives on the internet, some of those previously closed adoptions are turning into open adoptions, and I'm sure that you've heard stories about that. However, today, about 95% of adoptions are open. And really, that's great for the psychosocial effects of both the birth parents and, the adoptee, and then, of course, the adoptive parents as well. So if you're interested in adoption, an agency can really go through the details about that and steer you in the right direction. I do want to mention the cost of adoption. It really varies depending on what type of agency you're working with, if it's domestic, if it's international, but a ballpark range would be $20,000 to $50,000 typically per child that you adopt. So I am all about information and resource sharing. So through that, I've come across some really great groups that I want to share with you. The first one is called Adoption Network Cleveland. Now I'm based in Ohio, so that's how I know them, but they actually are a resource for people all over the country. They have different support groups for adoptees, for birth parents, for adoptive parents. They have education training if you're interested in adoption. They have an Adoption 101 class that you can sign up to take virtually. So they're not an agency, but more of an education portal and support portal. Also, I want to just mention that the adoption industry sometimes can have some ethical concerns. And by ethical concerns, I mean, there may be some agencies out there who are, using tactics to convince birth parents that they do want to go for a placement, and maybe not giving them all of their options and rights when they first find out about their pregnancy. So you really want to be careful that you're using an agency that's ethical and that's addressing the concerns of everyone and offering counseling services. So one of the ways that I like to research when young cancer patients come to me and say, I don't know where to start, who should I use for my adoption agency? This website called Adopt Match is really great. You can put your zip code in, and it will come up with a list of all of the ethical agencies in your area. So I always like to start there as a resource. And then two of the adoption agencies you'll find on Adopt Match, Just Choice and Adoption and Beyond. So Adoption and Beyond is based in Kansas. And when I say an agency is based in a certain state, it doesn't mean you have to live in that state to work with them, but just throwing it out there for geographical purposes. So the agency owner there, Stephanie, she has a lot of experience with placing children in families where one of the parents is a cancer survivor. And then Just Choice is an agency, an adoption agency in Ohio who I know a lot of people who have adopted through, and they're just really reputable and great. Like I mentioned, adoption can be really expensive. So there is a platform, a matching platform that I'm referencing here called Peartree. It's really great, and adoptive parents can create a profile for a minimal fee and see if they can get any type of matching there before they end up working with an agency or an attorney to finish the adoption process. it was started by a woman who is an adoptive mom, and she went through the process and said, need to do something better. We need to make it more affordable and accessible for everyone. So I definitely encourage you to check out these resources. If you personally are looking to adopt after cancer, or if you're a clinician who's working with patients. Okay, so gestational surrogacy. This is a very popular way to build a family for cancer survivors. Most of the patients that we're working with who are building a family through surrogacy, it's because they have a type of cancer where it would not be safe for them to get pregnant. For instance, the hormone positive types cancers, or they're taking a medication that's just not compatible with pregnancy. So with surrogacy, individual using donor sperm or eggs, or a couple create embryos together, and then that embryo is implanted into a surrogate. So the surrogate doesn't have any biological connection. The baby is born, placed into the arms of the intended parent or parents, and happily ever after. So surrogacy is great, especially for those who may have preserved eggs or embryos beforehand. Perhaps their cancer has progressed, perhaps they're on a new type of treatment that wouldn't allow for them to have a pregnancy. The downside, and it's a major downside of surrogacy, is the costs associated. So again, you can kind of do two different paths similar to adoption. You can work with an agency for surrogacy. They will take care of literally every single thing that goes into the process, and it's a complicated process. However, that's a very expensive journey. So that agency journey is going to cost at least $100,000. I see more typically between like $150,000 or a bit more than that. There are also young adult cancer patients and survivors who are going with an independent journey. And an independent journey means you find your own surrogate, and you take care of all of the paperwork and the process, and all of the behind the scenes work that that agency would do for you. And so, if you know someone who's interested in doing that independent journey, I've got a lot of resources, and I know people who have done it. There are Facebook groups where you can match intended parents with surrogates. I know somebody who literally went to their OBGYN's office and put flyers up all over the office and all around town to see if she could get a match for a gestational surrogate. I also outlined just some of the other costs associated with it. Some people who are gestational surrogates have health insurance that's surrogacy friendly. Others do not have a plan that would cover that. So one of the costs associated is going to the marketplace and buying a plan that's surrogate friendly. So you can see that could be anywhere from $15,000 to $30,000 to do that. If you work with an agency, you're going to have to compensate the surrogate. With an independent journey, depending on who it is, if you have a sister or a cousin who's willing to do that at no expense, that's going to save you a lot. So we've seen some really creative ways to minimize the costs in surrogacy. The other thing I wanted to mention is using donated embryos. So as many people are using assisted reproductive technology to create families, there's a lot of excessive creation of embryos. And so let's say a couple or an individual is feeling complete with their family size, but they may have 4 or 5 embryos left. And every year they're paying the storage fee, which we know can be so expensive. So an individual or a couple like that could go through a matching system, either at their clinic, or there's some national groups. One is called Empower with Moxie. And you'd be matched with intended parents who are wanting to carry that embryo and have a child with that embryo. So it's really a great option for those who want to carry. And also we've seen stories of people who have received donated embryos, and the baby is carried by a gestational surrogate. So the sky's the limit when it comes to creative family building for cancer survivors. And just want you to feel that hope and hear these stories so you know it's possible. And also, when you're counseling your patients, if you're a clinician on this call, this is a conversation that just shouldn't be a one and done conversation. In survivorship clinics, it should be brought up very frequently to see where people are and, sharing stories, connecting patients who have built families through, non-traditional means is so valuable in this process. So I'd also like to share a little bit of information about Worth the Wait. So as I mentioned, financial assistance is really the big program that we offer. So if you or someone you know is looking for some financial assistance, here's kind of just a run through of our basic requirements. So we're serving young adult cancer patients ages 39 and less, first-time parents who have a financial need. So we typically are looking at the median income by state to qualify that financial need, and who don't have insurance for fertility. And as you can see here, we have grants that are for fertility preservation, but we also have family building grants that can cover long-term storage for gametes, adoption, surrogacy, and IVF as well. And really each one of those things, as we've grown as a nonprofit, people have come to us and said, well, I can't afford the storage. And we said, okay, well, let's work with you to give you a grant on that. Or I need to purchase donor sperm because I'm going to be creating embryos. And, it's really been a beautiful thing to just see how our program has evolved over time. In addition to Worth the Wait, there's some really other great nonprofits that I want to make sure you're aware of. So Vernus Purse is a long-term storage discount available through Reprotect. So they're a national group that does cryopreservation. They have facilities in many states. If you have, definitely for males that are banking before cancer treatment, I always send them to the Reprotect site. They can put the zip code in, see if there's a facility close by. If they can then apply for the Vernus Purse discount, even better if they get that discount. There's also a nonprofit called Team Maggie's. They do fertility preservation grants for males and females, and they're really wonderful. And then Chick Mission does egg freezing only grants, and they're available for patients in a few different states. And then the SAM Fund does some family building grants that are similar to Worth the Waits as well. So one of our criteria, as I mentioned before, was insurance coverage. So insurance coverage for fertility preservation, as you can see from this map, is all over the place. So there's a group called the Alliance for Fertility Preservation, and they're behind all of these wonderful efforts to have mandated state coverage for fertility preservation. So all of the green states on this map are states where we have active coverage. And it's so wonderful that groups have been able to do this advocacy work. However, even in the states that are green in this map, for example, in California, the mandated coverage there only applies to a percentage of patients. So if you're a cancer patient on Medicaid, that mandate doesn't apply. Or if you're part of a self-funded insurance plan through your employer, that doesn't apply. So we're making good strides on getting bills or actually having coverage in these states, but so much work needs to be done. My husband Mike and I always say, like, Worth the Wait needs to go out of business. Our goal is to go out of business because we shouldn't have to provide the financial assistance. The insurance companies, there should be state mandates that cover all of this, so we're not putting this vulnerable population at risk. Also, as someone who's gone through infertility myself, you just can't ignore the psychosocial effects of cancer and infertility after cancer. So these are three really great groups that I like to refer patients to. All Paths Family Building, they actually have a support group monthly for cancer and fertility. And that is the most specific group I've ever found. So I'm really excited about that. Resolve is a national organization that has in-person and online support groups across the country. Not cancer specific, but it's still good for patients to, find their people who are going through this together. And then a newer group is called the Building Military Families Network. And they're a support group for active duty veterans and spouses who are affected with infertility. And they do have a lot of cancer patients within this group. And they're doing a lot of great meetups and things like that. So I will leave you with our website and our social media. If you have patients who are interested in applying for financial assistance, or you personally are interested, I'd love to chat with you and be a resource.
Thank you so much, both of you, for that wonderful overview and discussion. So I have some questions. I have one from the chat that I'm going to start off with, and then many more if we have the time. So the first one is for Dr. Constance. You talked a lot about chemotherapy and radiation being impacting fertility. Is there any research on immunotherapy's impact on fertility, and how do you advise patients?
Yeah, that's a great question. We unfortunately right now do not have very much data on the long-term impact of immunotherapy on either hormone production or fertility. It's probably low, but not well known yet. So when I speak with those patients, that's kind of how I start that discussion, is that our understanding of how those medications work, we believe the long-term risk to be low. We don't have good data. And so if they have time to freeze eggs beforehand and have the emotional and mental bandwidth to do so, always a good idea to do that. But most of the time with patients where that's the only therapy they're going to be getting, we'll just have that kind of risk counseling about ovarian reserve, and then just follow them, get a pre-treatment AMH level and then follow them after treatment so that we can intervene if we are seeing a decline afterwards.
Perfect. Thank you so much. My next question is for Megan, and I want to thank you first for sharing your story. We want to make sure that we amplify the voice of caregivers because they're very important in cancer survivorship, as well as the impact of cancer treatment and the journey on you as well. What advice do you have for couples to figure out what is their best choice for them before they get to the doctor's office? How do you, because we have talked about a lot of options here, and so how can families decide what is best for them?
Yeah. So unfortunately, I think a lot of it comes down to the money that you have available to spend. I hate that that's the answer, but I know for me and my husband, when we were going through things, we said, like, this is our limit before we went in to, finalize plans of, like, this is what we're willing to spend. Financially, but also emotionally, like, how many more rounds of this can I handle? The hormone injections, it's wonderful. You can get a lot of eggs, but it also makes you feel crazy. And people really have crazy responses. And, I get texts from people saying, nobody ever told me this was going to make me feel loony and what's going on. So I think it's important to just have those boundaries and talk about it, because once you get into the treatment, I feel like it just goes from one cycle to another. And, for the female, start your period. Okay, we're starting on the next thing. So have those boundaries and limitations in place up front.
Perfect. Thank you. So for Dr. Constance, what advice do you have for medical professionals who are uncomfortable talking about reproductive health and initiating these conversations? Are there any, what is your advice to them?
Yeah, I mean, I think that's a super fair question. I'm very comfortable with
Mm-hmm.
this conversation, these words. I know not all of us are. And so I think, it's important to at least be able to, in discussing risks and benefits, to be able to say, we know that this treatment that you're going to be getting may impact your ability to be a parent in the future. As long as we say at least that much, I think, that's important as part of that risk counseling. And then get them to your local reproductive endocrinologist to have that bigger discussion. And so I would say, find out who is in your area. A really good place to find reproductive endocrinologists with specific interest in and expertise in fertility preservation is the Oncofertility Consortium is one good place. You can search for the state or city that you're in and find a partner clinic nearby. Other things like the Livestrong Foundation, you can also go on their website and search what clinics have contracts with them, which provides financial assistance to patients as well. And so those are some good places to start if you don't know who's in your area to refer to. But I think that's at least the minimum step would be, this is a risk. I want you to go see this specialist to discuss it in more detail.
Thank you. Megan, so when finding your team to build families, do you have any advice on important questions that patients should ask their healthcare provider that you wish you would have known or asked when you started the process or through your work with working with others? Are there important questions to ask your healthcare team?
Absolutely. What I like to counsel patients on is ask for a discount. See who, sorry, Dr. Constance. But some of the clinics have a little bit more leeway than others. So I do tell patients, shop around if you have time. Now, this is more in the family building setting, but preservation things are so, urgent. But look at the Livestrong website, see who's going to give you a discount. Ask if you can get free or discounted drugs. There's a lot of programs around that. These patients are the most vulnerable patients. They've already been through so much. And there are a lot of clinics out there who will offer at least some type of discount if there, is no insurance coverage.
Perfect. Thank you. And this is a question maybe for both of you. I don't know if you have experience in this area, so I'm going to ask it, and then if we don't know, well, we can think about it. But what is the process? I know we work with a lot of young adults, but for pediatrics and fertility, you mentioned it in your presentation. How complicated is that process, and is there a recommendation around counseling or understanding this added element and family building with involving children and preserving their fertility? It does seem like a more complicated process.
Yeah, we could do like a whole 30-minute talk just on like all of the psychosocial, legal, and medical, factors that go into that. But briefly,
Yes.
it is still recommended. So the American Academy of Pediatrics and the American Society of Clinical Oncology both still recommend that these conversations are had with families of children before treatment as well. So, when possible, there is the option of ovarian tissue or testicular tissue freezing. I'd say the biggest logistical complication with that is just that it's not offered as broadly everywhere as like egg and sperm freezing are. And so there may be travel required with that, which is oftentimes a limiting factor. And so, for a lot of times, if there's not someplace locally or nearby that offers that and travel is not an option for whatever reason, it's still helpful to have those conversations about what are we going to do after treatment to monitor, make sure you go through puberty. If you don't go through puberty on your own because of endocrine, insults, how are we going to help you go through puberty? And then I'll have conversations with parents at that time too about what those other options for family building. Sometimes people have never thought about donor eggs or donor sperm or things like that. And so, kind of just providing some reassurance that like this isn't the end of the path to parenthood potentially, but that path, we may need to start preparing now for that path looking differently than we expected it to.
Okay. So on that note and that positive, I love that you ended on such a positive note of hope. Megan, I want to give you the last word of just a message to everyone on the call. Anything that you would like to end with today around the
Sure.
topic of family building?
Yeah, I actually just saw something in the Q&A, and someone was asking about how often are fertility preservation conversations happening. JAMA just had an article published, I think it was just in November. There's a really amazing group at Vanderbilt, Dr. Halawati, and she did a research study about conversations for fertility preservation. 50% are being counseled. And if you look up that study, or I can share it with you after, Veronica, to send it, it's really interesting because it goes through the different diagnoses and who is more likely to be counseled versus not likely. So just thought that was very timely that I'd share.
Absolutely. And we posted it in the chat. And know too that NCCS in our survey actually is around 80%. That's the number that we have reported in the last year, but it has gone down in different stages at different times. It's lower, but still, even with ours, 20% not being supported in our survey as well. So thank you both for being with us today. Thank you to our audience who joined us for this important topic. And feel free to send us an email if you need anything. The slides and the recording will be in your inbox later this week or early next week. Have a great day, everybody.